colleagues, welcome to today's EACVI webinar on clinical data to demonstrate the clinical effectiveness and the cost efficiency of contrast-enhanced stress echocardiography in patients with chest pain. I'm your host for this webinar. My name is Valeria Pergola from Padua University Hospital, and I have the pleasure of being joined by Dr. Nicola Gaibazzi from Parma University Hospital and Dr. Rajdeep Kattar from Royal Brompton and Harefield NHS Trust. The definition of ischemic heart disease often includes a description of coronary atherosclerotic disease. According to the recent guidelines for the management and diagnosis of chronic coronary syndrome, the initial approach to a patient with a high clinical likelihood of obstructive coronary artery disease is to perform myocardial stress imaging. But there is ample evidence that between 10 and 15% of patients admitted for non-ST segment elevation acute coronary syndrome show no obstructive or only mild coronary artery disease at angiography. Therefore, the aim of this webinar is to give you a better understanding of how we use contrast in different stress echo modalities, exercise, epiridamol, and dobutamine, both for assessing perfusion and wall motion abnormalities. During the webinar, it will also be explained the incremental value of perfusion and coronary flow reserve over wall motion abnormalities, both in the detection of coronary artery abnormalities and for prognostic value. Finally, this webinar will highlight how cost-effective is the use of contrast during stress imaging compared to other modalities. This will be illustrated through clinical case presentation. This session is highly interactive, and we strongly encourage you to actively participate by sending your questions and comments at any time during the webinar through the chat. For your best learning experience, we also invite you to participate online in the assessment session in the form of MCQs that will be submitted through the presentation. This program is supported by Bracco Milan, Italy, in the form of an educational grant. I will now hand over to Dr. Gaibazzi for the presentation. Please, Nicola.
Thank you, Valeria. Thank you for having me here. I think this is just the first slide. The subtitle here is more than just myocardial perfusion imaging, and we tried to discover through several cases that there is more than myocardial perfusion in the use of contrast. So how does myocardial perfusion look like? This is an example. On the left you can see a real-time flash replenishment sequence, which is based on an impulse, a high mechanical index impulse that breaks the microbubbles, and then you see how the microbubbles replenish the myocardium. The second in the mid is an image of the same four-chamber examination, in this case using the triggered imaging modality, which is just taking one or more frames on the end systolic peak, so that the images can show you in each cycle how post-flash there is no microbubbles in the myocardium, and then it replenishes gradually. 2 seconds is at stress phase is the maximum time allowed for replenishment in, let's say, non-obstructive coronary artery disease. On the right, you can see an abnormal image with a defect clearly seen here in the mid and in the basal lateral segments, in the subendocardium and mid-myocardium particularly. So there is more than myocardial perfusion, since wall motion can be much better analyzed, assessed using contrast in the 100% of patients. You can see myocardial perfusion as we have seen, but you can further see another and measure another important variable, which is coronary flow reserve in the LAD, in the mid-distal LAD, using the Doppler measurement, which is not so widespread, but it's very useful, and it's now being published also in American journals and getting much more widespread. For chamber, this is the easy MCQ1 case. So MCQ means that I'm not saying what the images are showing, and you will try to understand this in the end, in the last slide of the case. So just to illustrate a 4-chamber, a 2-chamber, so images are not very clear, maybe they're not gain enough. But then using contrast for wall motion, you can see images much more defined in 4 and 2-chamber. This is the rest phase of the stress echo. After dipyridamole, all the cases you're going to see in this presentation of mine are going to be done with dipyridamole vasodilation, dipyridamole 0.84, so the high dose in 6 minutes. And this is the stress phase, still with contrast. This is the 4-chamber, this is the 2-chamber, this is the 3-chamber, and this is a still frame of the 4-chamber at 2 seconds after flash imaging, which breaks the bubbles, and this is the situation after 2 seconds. Let's see this again for a couple of seconds. So 4-chamber, 2-chamber, 3-chamber. So the easy case is this one, and you should try to understand which one is the right answer. Positive for reversible wall motion abnormalities only with normal perfusion. Positive for reversible perfusion abnormalities only. Positive for both perfusion and wall motion reversible abnormalities, or completely negative. So again, look at the images. This is the rest phase, 4-chamber, 2-chamber. Then you have the stress phase, 4-chamber and 2-chamber.
Okay, our viewers, they have 1 minute to answer the question. Meanwhile, I would like to ask you, which are the tips and tricks that we can use, to improve the quality of our contrast imaging?
Yes. First of all, for people not practicing contrast, the first important thing to know is that when you image with contrast, you need to lower your mechanical index down to 0.1 or something around, so that you can avoid to break the microbubbles while still gaining good imaging. Real-time imaging or trigger that you want. There are 2 ways to infuse contrast, which is for perfusion, the pump and the continuous infusion is probably the best way to do it for technical reasons. But for example, the cases you're seeing here are done with bolus of contrast, yes, yeah. 0.5 milliliter sonov in this case. So the time you have to image is quite long for wall motion, but not for perfusion. So yeah. You have to be quite experienced in getting perfusion from your images using bolus. When you start learning contrast, it's much better to use the pump. Yes.
Now, 65% answered C. Do you agree with his answer, Raja?
Yes,
what
yes,
do you
I think
think?
so.
Yes,
Yeah.
I think it's okay.
Yeah.
This is the right
The
question.
easy one.
Yes, that's the easy one. We'll have something worse. This is not an MCQ case, so we can discuss it in real time. So this is a 4-chamber view, this is a 2-chamber view, this is a 3-chamber view. Quality of images is quite perfect, and with contrast you're seeing even better. One of the gains of contrast is that often you cannot see without contrast under the papillary muscle, while you can see the endocardium using contrast, 2-chamber and 3-chamber. This is the rest phase. Stress phase, it is not so fast actually, it's just a video reproduction which goes so fast, because with dipyridamole typically doesn't increase your heart rate more than 100 beats per minute. So 4-chamber, 2-chamber and 3-chamber. You may discuss a little bit this segment, but when you're close to the mitral valve, you should be careful to call positive test. Yeah. This is normal in my view. And this is the myocardial perfusion imaging at stress. And I love to show borderline cases and not the best quality cases you have, because perfusion is not easy and should be managed and interpreted with caution. So sure. When you have a sequence like this one, you can probably see, let's try to fix it here. So this is the flash phase, the flash impulses actually, and then you follow how it replenishes. This is the microbubbles that are completely distracted in the myocardium, and then the next phase is see how it replenishes. If it replenishes fully within 2 seconds, 1.52 seconds, it's a normal replenishment, so no perfusion defect. While in this case you can see several defects actually, which are probably in different territories, coronary territories. So I would call this, well, I would have doubts probably positive perfusion, so abnormal perfusion and stress, but I'm not so sure as a clinician in this case. You can fix all the defects that you have seen at 2 seconds after the flash impulse. So that's where it comes to help another variable in my view, which is the Doppler coronary flow velocity reserve, which is the ratio between the coronary flow velocity at stress times divided by the velocity at rest, which should be more than 2 to be normal, to be in the absence of coronary artery disease, epicardial coronary artery disease, and in the absence of microvascular disease. So in this case, this is less than 2. This is less than 2. So this is something that goes together with some defects in the LAD, but may also be microvascular obstruction. In this case, we typically send patients to CTA, which with its high negative predictive value, in cases you're wrong and you're just dreaming on stress echo, may confirm that there's nothing. But in this case, obviously, there is a mid-distal LAD disease, obstructive, and some calcium all around the coronaries. So in this case, perfusion and CFR helped each other to understand what was the next step. This is instead an MCQ case, so that I won't comment on what I see, but just show it to you. This is a 4-chamber at stress phase. So this is after dipyridamole, high dose accelerated, 6 minutes. It is typical that heart rate is slightly higher when you use the accelerated 0.84. 4-chamber, 2-chamber, 3-chamber, very good images. I'm not saying what I see. And then you have the perfusion phase. Again, see this is a 4-chamber, this is a 2-chamber, and this is a 3-chamber. Again, you can see the flash. Let's see together without commenting on the results. Flash, then you will see black myocardium after the microbubbles have been distracted, and then you see how it replenishes. And the same you can see in 2 and 3 chambers. Don't forget, it's 1.52 seconds time for complete replenishment is allowed. But this is the third variable we were mentioning that is helped a lot by contrast. You can measure coronary flow reserve, obviously, without contrast, but contrast helps a lot. You see 2 or 3 chamber views. This is more of a 3-chamber probably. It's between the 2 and 3 chamber. You can just, with a proper setting, which is appropriate for coronary flow imaging, you can just put your sample here and see several centimeters of the LAD. It's very easy. While measuring coronary flow reserve is a little bit tricky without contrast. With contrast, it's very, very easy. And you can see this is the velocity at stress, and this is the velocity at rest, and I won't comment on this. So now, what's the result, in your opinion, of this stress echo? Again, this is wall motion at peak, this is perfusion at peak stress, and this is the ratio between the stress and rest. Positive for reversible wall motion abnormalities only, positive for reversible perfusion abnormalities only, positive for both perfusion and wall motion abnormalities and with reduced coronary flow velocity reserve, normal wall motion and perfusion but reduced coronary flow velocity reserve, normal wall motion, abnormal perfusion, and normal CFVR. Take your time.
So, Nicola, they have 1 minute to answer, but it would be interesting for our viewers to know how do you take the measurement of coronary flow reserve with Doppler, because maybe it can be a little bit tricky with the contrast?
Well, yes, it's not a widespread technique, unfortunately, because with contrast, it's very, very easy to be done. You need to have the appropriate setting in the machine, which is the same setting used for coronary flow velocity reserve without contrast. Simply obtain lowering the mechanical index as you do for every time you use contrast. Yes, so in this case also, both for color and for Doppler measurement, you should lower your mechanical index down to almost 0 or 0.1, something around there. So it's not, you obtain very good images for color, they are magnificent, but not for pulsed wave Doppler. So the curve, the TVI, is not perfectly traceable, but you can easily see the peak diastolic velocity, which is the thing you use to put in the equation.
Absolutely, absolutely. Right. So 47% of our viewers answered positive for perfusion and wall motion reversible abnormalities and reduced coronary flow reserve. But 34% of the people answered normal wall motion and perfusion but reduced coronary flow reserve. That's tricky.
That means that perfusion isn't easy to be analyzed, to be assessed. This is a typical normal perfusion test, for example, where you can surely see some blackish zones here, for example, in the basal anterior in two chamber, or in some most basal segments or half segments, but this is typical and normal of a well-conducted perfusion study. This is actually technically high quality. So you should not hope to have better images than these during perfusion stress. So this is the reason why you need a learning curve, because actually the right answer is that normal wall motion. I think this is quite clear, but maybe perfusion could be tricky if people is not accustomed to reading, to assessing perfusion, but this is a typical normal after few. But that also explains one of the problems of myocardial perfusion. That's why I'm always saying that contrast is more than perfusion, because perfusion is the top quality that you can reach after a learning curve, but contrast helps you a lot for wall motion also and for Doppler. So finally you will be also able to read perfusion.
How long it will take usually?
I don't know, but some dedicated time is needed. And then you need to do not just one case a year. You need to build a learning curve in my way.
What is in your experience?
Again, I think perfusion assessment is quite challenging. There are many pitfalls, and you can see many artifacts. So you really have to be very familiar with the machine settings. To be familiar with what is the right level of gain, the right level of contrast, make sure there's no blooming artifacts. So there is, I think it is quite a learning curve, and I would say possibly more than for normal stress echocardiography. Again, I don't have a specific number, but I think you need to do a lot in a short space of time.
Like 100 cases?
Yeah, I think, yes. So my instinct was at least 100 cases. To, as I say, to be aware of the pitfalls and to actually do it yourself to really get the understanding of the technical difficulties.
Yeah, sure.
It has the same problems that you can find in CMR or other type of imaging with artifacts. The problem, probably the additional problem, is that you need to put your hands on the machine to be able to correct them and build personal experience. This is the last case, the fourth case. And this is not an MCQ, so we can talk about it. This is, let's call it suspected chronic coronary syndrome after a screening treadmill ECG in an athlete. It's not a real coronary. The point is, we love in medicine to classify, to label things, but sometimes you find people like this gentleman who's a 50-year-old marathon runner who did his treadmill ECG, which is needed for screening in Italy at least, before competitions, and you find something like, it happens a lot, an ST downsloping tract starting early during the treadmill exercise, but with no chest pain or equivalent symptoms, and you don't know what to do actually. One of my colleagues probably asked for a SPECT imaging, which was completely normal in its imaging phase, but not in the ECG, which replicated the behavior of the treadmill ECG with the downsloping ST tract. We decided to do another examination, which is a stress echo, and you can see here a rest in the upper images and the stress phase in the lower images with 4-chamber, 2-chamber again, 4-chamber here and 2-chamber at stress, and it looks like wall motion is actually perfect. And myocardial perfusion stress is also actually perfect. And this is what we saw probably in the prior case. See, this is after the flash, and then you see how it replenishes. This is an artifact. You always have to know and think about artifacts when you're using contrast, because artifacts are there as they are in 2D standard imaging, but you don't know that you're looking at them, so you just see less signal, but it may be because this is a side lobe and so on. So that's where the experience. This is a normal myocardial perfusion stress. So it is normal for wall motion, we are happy with that. It's normal with perfusion, and we are happy with that. And we measure, this is the systole and this is the diastole at rest, and this is the systole and this is the diastole at stress. And we see a 2.0 CFR in the LAD, which is not normal in an athlete. It's normal in an old man or in an adult who's not exercising, but in a marathon runner, you would expect much more than this. So this was what prompted us to ask for another examination, unfortunately, another test, which is a CTA, which brings up this quite big and positive remodeled low attenuation plaque, which was not fully obstructive in the proximal LAD, but it's worrisome to some extent. And we now know that positive remodeled and low attenuation plaques are probably more vulnerable than other plaques. And we don't know what to do, actually. Medical therapy is probably the only thing you should do. But the putting together wall motion and perfusion, which were normal, but also CFVR in the LAD, gave us the occasion to at least know what was the anatomic situation of the coronaries of this guy. And so putting together with contrast wall motion, perfusion, and coronary flow reserve using Doppler is very, very useful to have more variables. Then it becomes quite difficult how to manage the patient after the ischemia trial, but we know we will work on that.
Absolutely.
Thank you.
So there are a couple of interesting questions, Nicola. Is there any role for the pyridamol stress test without contrast?
Well, definitely.
Is it useful, you know, because probably what
you're talking about, I mean, he's talking probably in the question about simply using dipyridamol
without contrast.
Yes, we have been practicing mostly in Europe, I would say, in Italy a lot, South America, but there are tons of papers published on the value of dipyridamol. I think here there's a misunderstanding about dipyridamol. Vasodilators have been used for perfusion, for example. Many centers used in other modalities, SPECT or CMR or echo, contrast echo for perfusion, with the intent to evoke vasodilation for perfusion, imaging, stress, and rest. And that dose is what I call low dose. It's not low dose, let's call it mid dose, 0.56 milligrams per kilo. But the dose of 0.84 milligrams per kilo in 6 minutes, what's called the accelerated, and is present in the European recommendations, is one of the stressors you can use also for wall motion, not only for perfusion. So you can use dobutamine, exercise, or dipyridamol, or you can also use adenosine. I'm not very
attracted by
adenosine, but using dipyridamol at this dose is similar. There has been some talk about dobutamine being more sensitive or exercise being more sensitive, but maybe a little bit less specific. But basically, accuracy is superimposable for what we have published nowadays. So dipyridamol is okay also without contrast, for wall motion and coronary flow reserve.
Probably what they want to know is as perfusion detects earlier abnormalities than wall motion, you know, the added value of perfusion, of contrast.
Yes, anytime we add something to stress echo, we discover that that new variable is actually quite useful for both diagnosis and prognosis. We started with wall motion, and wall motion sets the threshold, which is very, very high. You need to have very severe CAD. And if your aim is just looking at patients with very severe CAD, you should pay more attention to wall motion, obviously, to the highest risk of patients. But when you have only myocardial perfusion defects and no wall motion defects, or when you have CFR, which is reduced, and you have normal wall motion, this is clearly, and it's been published in thousands of patients, that also from my group, that this is an intermediate risk, which is similar to CMR, for example. If you have perfusion or wall motion, this is the same trend in higher and higher risk.
Yeah. What is your opinion about this?
Yeah, I think a lot of this comes down to personal experience and use. So, as we say, there are three main modalities we can use: treadmill exercise or pharmacological. So you have the choice of dobutamine, you have dipyridamole. In the UK, predominantly for pharmacological testing, it's dobutamine. But that, again, is just down to our own individual experience. As Nicola has said, the diagnostic accuracies of all these three different stress modalities is very similar.
Yeah. Another question. How much contrast to use for myocardial perfusion?
Well, it comes to the way you use contrast. If you use infusion, continuous infusion, which is the best modality if you want to, in particular if you want to learn, to have more time to assess myocardial perfusion so that you have a steady state and you could also theoretically, I think not practically, perform quantitative measures, you have to use quite a lot of contrast because you need to charge your pump with few vials and have an examination. This is not the way we use contrast for perfusion. It is a little bit more tricky. You need to be a little bit faster in your assessment, but you can use bolus. So when you inject the bolus, you have a steady state at the flat of the curve. You have this for just maybe 15-20 seconds, which are good for perfusion assessment. You should use that. If you are using your flash replenishment sequence just when you are going up in the curve or when you're going down, you will have under sensitivity or over sensitivity of defects. So you have to know the method, but it's not that different from other methods. If you inject with CT or CMR at the wrong time, you are going to have defects.
Wrong result, yes. Yeah? Then can we use speckle tracking during stress echo? What is your opinion?
Well, we don't routinely use speckle tracking for stress echo. We use it for resting images, just to look at subclinical myocardial function. With stress, the difficulty is the frame rate with exercise. So we use a lot of exercise and dobutamine. So we're more dependent on increases in heart rate. And that makes speckle tracking more challenging.
Difficult, more challenging.
Yeah, so we don't do it routinely.
Yes. Which contrast agent do you normally use in your clinical practice?
Well, I'm not sure we should say names of drugs in this webinar, right? But I'm basically using the one that is available in Italy, which is only one. Yes.
Mm-hmm. Yeah.
Okay. What about you?
So we use also, I mean, Sonoview is the one that's predominantly used.
Now, there is another, probably the last question we can answer. On the last case, why all stress tests were normal? What is your opinion?
While, do you think he means stress test?
Yes, was normal and...
in the last case, there was normal wall motion, normal perfusion, but not CF.
Exactly.
Okay, but well, you have seen from the CT there was a non-obstructive plaque. So,
do you think this is enough? Probably this is the question that they want to
well, when we are getting into CAD, we are clearly discovering that there's anatomic and functional disease. And with the CFVR, you are measuring, and the myocardial perfusion also, we are measuring more. We are more sensitive to microvascular disease. And so what you measure is the anatomic epicardial disease plus the microvascular disease, which is more prone to be abnormal with perfusion, and because they sum up. wall motion is really terrific ischemia in my view, and so that's why in some studies when you used only wall motion compared to CT, you had 50% sensitivity, and that's the reason why, because you're just going to discover which may be good for you, but why not use several variables and then decide in that patient, in that old or young patient you want to be.
Absolutely. Can we use with stress echo, with exercise stress echo? Of course, yes.
Yes, sure.
Qatar is now showing that.
Now I will hand over to Raj because time is flying. And
thank you very much, and to the organisers for inviting me to speak today. So in our lab, we do a lot of treadmill exercise echocardiography. So for any patient who can exercise, our preference is treadmill exercise. So I would say that's approximately 75% of patients. And for pharmacological testing, we use all sorts, but predominantly dobutamine. So I'm going to show you two cases where we've used treadmill exercise echocardiography. Two clinical cases which I hope are of interest. These are my disclosures. So the first case is a 52-year-old woman who presents with predominant shortness of breath for a period of about 6 months and occasional chest discomfort on exertion. She has coronary risk factors of hypertension, treated for the last 2 years with perindopril, 4 milligrams a day, and she has recently been found to have a high total cholesterol level of 6.7 millimoles per litre. She's a non-smoker, occasional drinker, no family history of heart disease, and she is at least moderately overweight, with a BMI of 35 kilograms per metre squared. The ECG also is clearly abnormal, showing left axis deviation and left bundle branch block. So the first thing we did was a resting echocardiogram. And so here is the parasternal long axis view on the left. And you can see that typical pattern of septal dysynchrony consistent with left bundle branch block. The LV cavity is mildly dilated, as you can also see in the short axis view. And again, you see good wall thickening in all of the walls, but this septal dysynchrony consistent with the left bundle branch block. Moving to the apical view, the four-chamber view on the left here, we can see the endocardium of the septum reasonably well, but we really have no impression of the endocardium at the apex and at the lateral wall. And under those circumstances, it's very difficult to estimate ejection fraction and to comment on regional wall motion abnormality. And as we know from the guidelines for the use of contrast, if you have at least 2 contiguous segments which are not visible of the endocardium, then that is a good indication for using contrast. So this is precisely what we did, and the image on the right shows you the contrast-enhanced views. Now you can see the lateral wall very nicely. You can see the apex very nicely, and the septum. You note again, the left ventricle is mildly dilated, but the lateral wall contracts well, and the septum is desynchronous. The biplane ejection fraction using contrast was mildly reduced at 44%. So we proceeded to doing a stress echocardiogram. Now, many non-invasive imaging techniques have difficulty when you have a patient with left bundle branch block and markedly overweight, not ideal for SPECT imaging, not necessarily ideal for CT even if the patient is particularly overweight. So there are difficulties with non-invasive tests, but we generally like the functional approach. So we did a treadmill exercise echocardiogram. The patient exercised for only 3.5 minutes of Bruce protocol treadmill. That's about 4 METs workload. She had a resting sinus tachycardia and an accelerated heart rate response with very limited exercise. What is interesting is that she had a very blunted blood pressure response, a very minimal increase in her systolic blood pressure. And the test was terminated by shortness of breath rather than chest pain. Now here are the findings from the stress echocardiogram. The images on the left show you those at rest. So the apical 4-chamber view at rest, the apical 2-chamber view at rest. So when we do treadmill exercise, what we do is when the patient is coming towards the end of exercise, we inject the bolus of contrast. The patient is then moved to the couch. That takes about 10 to 15 seconds, and then we have about 60 seconds to acquire all of the images, which we do with continuous capture. And so these are the images immediately post-exercise, taken very promptly. And you'll notice that this really is not a normal response to exercise. What should happen is that the left ventricular myocardium should have increased contractility in all of the myocardial walls, but this is not the case here, because you see the cavity has become dilated. And in fact, the ejection fraction has reduced to approximately 20 to 25%. And the same is true in the apical two-chamber view. There's dilatation and reduced contraction of the anterior wall, and perhaps less so of the inferior wall. The apical three-chamber view on the top, so again, resting images on the left, immediate post-exercise images on the right, and again, the same pattern of cavity dilatation and overall reduced contraction of all of the left ventricular wall. So here there is global impairment of left ventricular systolic function rather than a specific single regional wall motion abnormality. So my question to you, it's a clinical question really, what would be your next investigation? Would it be a CT coronary angiogram? Would you prefer functional testing with CMR perfusion or SPECT perfusion imaging, or go directly to invasive coronary angiography? Or do you have another thought in mind?
So as usual, our viewers will have 1 minute to answer. What I want to ask you, as there are some questions from our viewers, can we use contrast echo with speckle tracking?
So, like I said to you, I think it's very difficult. So what you can do, we have published a paper on this, is let's say that you're doing the contrast echo at rest for left ventricular pacification. You can actually get speckle tracking images when you do the high impulse flash to get rid of the contrast in the myocardium, and then use the speckle tracking to look at that darkened myocardial region. So it is possible to do it, and actually the signals are quite good. So in the contrast of resting contrast echo, yes, it's possible. But again, the caveats with stress are the increase
because
in
of the heart rate, of
Yeah.
course, is not doable.
Yeah.
So 57% of our viewers answered invasive coronary angiography. Is what you did?
Well, I think it's a very reasonable suggestion. People are obviously thinking, could this be multivessel disease? Or at least the majority are thinking, could this be multivessel disease? And so we should really find out by direct coronary angiography, and this could be prognostically important. So it's a very valid reason to do that. But we did 5. We did other.
Something else.
Yeah. So, and of course, this is a contrast echo workshop, so I've used this example for that reason also. When the patient had the wall motion images taken, her heart rate was still quite high at 128 beats per minute. So when the patient lies on the couch, so this is for practical purposes, we then connect the SonoView contrast infusion. And so we have continued steady state flow of contrast. So we then assess myocardial perfusion. And this is what we did in her case. So this is the same sitting. So they've had the resting echo, they've had the stress echo, and now they're having the myocardial contrast echo. And as Nicola has already described to you before, the flash indicates a high energy impulse which destroys the microbubbles in the myocardium. And then you'll note immediately after the flash, the myocardium goes black and then replenishes within 1 second. So this is normal myocardial perfusion, and yet you can see the left ventricle is more dilated, and we've already seen that there's myocardial dysfunction. So the implication from this is that this is not coronary artery disease, certainly not multivessel coronary artery disease. So in one sitting, I think, so the question that I had in my mind was, is this multivessel disease, or is this intrinsic myocardial dysfunction? Given the resting abnormalities. So the patient was actually then referred to the cardiomyopathy service. And we agreed that we should do a CMR scan to look for mid-wall fibrosis, and they could do perfusion at the same time as well. So we have CMR perfusion with adenosine, I believe they use. And the CMR scan showed mildly increased left ventricular volume, as with echo. Ejection fraction was reduced because in the CMR lab, the ejection fraction lower limit is 60%. There was no mid-wall fibrosis, and there was normal resting and stress myocardial perfusion. So further confirming that this is really not coronary artery disease, and it was felt that this was an early dilated cardiomyopathy. Somewhere along the way, many months later, the patient actually did undergo a CT coronary angiogram, and you'll note a calcium score of 0. So this is a very interesting case. This is, if we take it in the context of coronary artery disease, this is a, in inverted commas, a false positive test. But what it is showing is true pathology, true findings, and not relevant to coronary artery disease. It's another disease process. The patient was then treated with beta blockers, ARBs, and so on and so forth. And the patient had maintained the left ventricular function over the following 3 years with an improvement in symptoms.
Can we say, Raj, that the fact that the patient had normal perfusion was a positive factor in the sense that they have low event rate usually,
so
what is the value, the prognostic value of a normal?
Well, yes, I think in the context of coronary artery disease, as with SPECT imaging, a normal SPECT perfusion scan indicates a very low risk of a coronary event. Normal motion indicates normal, a good outcome. So this patient really is more driven, the prognosis is more driven by the left ventricular dysfunction and the other pathology. The fact that perfusion is normal is obviously a bonus for the patient.
Of course. What is your experience?
Absolutely right. It's very interesting in other settings when you can analyze perfusion, assess perfusion, for example, in viability tests.
Absolutely, yes.
That is a major prognostic factor. That there's viability at least at the perfusion level, but not appropriate to this case. But when you have the assessment of perfusion, even at rest in cases of viability, obviously with different cutoffs, 8 seconds or rather, this is a very and the group of
value, to
yes,
the
Raj
exam that
published a lot on this
in
the early days of perfusion. Right?
Yeah. And the other thing I think relevant to this case is that the patient had morbid obesity, and we have shown that in all comers with a body mass index over 35, that we have a 96% feasibility of doing stress echo with contrast. And this is in all comers in standard clinical practice.
This is an added value of contrast because without it, of course, it is not feasible. The pictures are not enough good to have a diagnostic study, do you agree, Nicole?
Yeah, absolutely. So my second case is, I think we've discussed the value in this case. My second case is a 33-year-old gentleman of Pakistani origin who had a family history of hypercholesterolemia, and he himself had hypercholesterolemia, who presented with an episode of central chest discomfort when running for a bus to work. It was an isolated episode, but he was obviously quite alert to the idea that, given his family history, that he wanted to be sure that he did not have coronary artery disease. A CT coronary angiogram was done, and indeed it did show atherosclerotic disease. There was an eccentric lesion in the left anterior descending artery, and there was also moderate ostial left circumflex disease. He then went on to have invasive coronary angiography. And you'll note on the image on the top left that there is an ostial stenosis in the left anterior descending artery. And also, if you look at the caliber of the left main stem, it's very similar to that of the left circumflex, very similar to that of the LAD, whereas it should be really bigger. It should be at least 1.5 times bigger in caliber. So the implication is that there's some left main stem disease and ostial LAD disease. There's also some diffuse disease of the PDA branch of the right coronary artery. So he has clear coronary artery disease. And my clinical question to you is, what would you do next? Now, this case was from 2013, And obviously, we've already mentioned the ischemia trial and the implications of that. So what would you do? Would it be medical therapy? Would you opt for a percutaneous coronary interventional approach? Or would you recommend CAB surgery? Another option is to perform functional testing for more information, or other ideas that you might have.
So again, we have 1 minute to discuss. There are some questions we would like to answer. Do you use contrast in every stress echo?
So we use contrast in the majority of stress echo. I would say we use it in 85 to 90% of patients. If the images are really excellent without contrast, and the patient has a low likelihood of coronary disease, and we're seeing more and more of these patients with low likelihood, to be honest with you, we may avoid contrast. But I think contrast is very good for looking at the apex. And I can show you examples where there's a lot of trabeculation at the apex. The 2D images are great, but you don't see the true wall, the true compacted,
yes.
and you don't see the true compacted myocardium.
Yes.
So I think if in doubt, use contrast, and certainly have a low threshold for using it, because it also helps a lot with the interpretation of wall motion abnormality, and we know that from previous studies.
Yeah, also because you can foreshorten a little bit the pictures, and then you cannot see the true apex, while with the contrast you are better oriented, I believe. What do you think, Nicole? Yeah. So 51% will go for a functional test. This is what you need, I'm sure.
A very good answer. So that's what we did. We proceeded to a stress echocardiogram. I think it's useful to have exercise information, because exercise duration itself, the exercise workload, is a prognostic indicator. And this patient actually exercised for 12 minutes of Bruce protocol, which is a high level of exercise. It's a very rapid walk at about 17-degree incline. He achieved his target heart rate, and he stopped because of shortness of breath and mild chest discomfort. Again, the images on the left are at rest, and on the right in this quad screen are immediately after exercise. And again, you'll notice, like with the previous case, there is left ventricular cavity dilatation, both in the 4-chamber view and the 2-chamber view. And then when you assess the regions, the septum, apex, distal to mid-lateral wall, and I would argue even the basal-lateral wall, are severely hypokinetic. Although there is movement, actually there's not a lot of thickening here.
Yeah.
So there is a lot of ischemia, and also true in the inferior wall, apex, anterior wall. And you see in the short axis view, the only area that seems to be contracting reasonably well is the infralateral wall. The rest are reduced, and it's quite interesting. There's a little perfusion defect here, which might indicate, which is another factor that suggests that there's reduced blood flow in this area. So global reduction in wall motion with exercise, perhaps sparing the infralateral wall. So on the one hand, we have somebody who's symptomatic, but really only at a high level of exercise. But on the other hand, we have the same patient who has a lot of ischemia with treadmill testing. So this was open to a lot of discussion. And obviously there was a lot of patient interaction as well about what should be done. And the patient opted for a percutaneous approach to treatment and had a PCI to the left main stem and the ostial LAD, and also to the distal right coronary artery. Unfortunately, however, he developed a recurrence of chest pain, again at with physical exercises really. And a stress echocardiogram was then repeated. I think on this occasion, although he exercised for the same amount of time and did develop chest pain, there was less ischemia, there's less dilatation of the left ventricular cavity. But you'll notice in the parasternal long axis view, the infralateral wall is severely hypokinetic with exercise. And I would argue that the septum also does not contract as vigorously as it should with exercise. So there is ischemia, not as widespread as before, but certainly there, and he continues to have the same symptoms. This was the angiogram after the stress echo, and you see a very tight stenosis in the ostial LAD within the previously implanted stent, and actually there's also some impingement now of the ostial left circumflex artery. CABG surgery was recommended, but the patient opted for a repeat PCI procedure, which was, certainly feasible, so that is what he went on to have. And this time he had bifurcation stenting of the LAD and left circumflex artery. But unfortunately, again, came back with symptoms, a critical lesion in the LAD and a total occlusion of the left circumflex stent. He agreed to CABG surgery and underwent Lima and grafting and a radial graft to the obtuse marginal branch. A very unfortunate chap, this patient. More chest pain, more angina, 3 months after surgery. And on this occasion, an exercise echo was again repeated, less exercise duration, but again, clear ischemia in the infralateral wall. Compare it with the resting image. Look at the thickening of the myocardium at rest on the left and compare that to immediately after exercise. So there is infralateral wall ischemia. A further final angiogram showed that there was an insertion point stenosis just beyond the obtuse marginal graft, consistent with the infralateral ischemia. So here is the previous stent, this is the graft, and there is the stenosis. He underwent PCI to the native obtuse marginal branch via the radial graft, and I'm pleased to say, and I think everybody's breathing a sigh of relief, that he had no recurrence of symptoms. And this was back in 2015. And a stress echo performed in 2018 did not show any ischemia. So this case points out that really there are no safety concerns with serial testing with stress echocardiography or indeed with the use of contrast. And that is unlike many other tests. Very good at regionalizing ischemia. We've shown infralateral ischemia, we've shown lateral, septal, apical. If you have good images, you can very happily do treadmill exercise with contrast. So these are the main learning points from this case. Thank you for your attention.
Thank you, Raj. Now, a lot of questions are coming regarding safety with contrast. What is your experience about allergic reaction and...
So, I mean, in the published literature, we quote also a complication rate of 1 in 10,000 with contrast.
Which is very, very low.
Which is very low, of an allergic reaction. So we have no qualms about using contrast, as I've told you already. And that is more or less our experience. We do about 1,100 to 1,200 stress echoes a year. And in the last 8 years, since I've been working at Royal Brompton Hospital, we have had 2 allergic reactions.
Yeah.
So it's a very, very low risk. And we don't really factor it as a consideration.
Yes, it's the same profile of an antibiotic or analgesic.
Well, better than I would say than a lot of antibiotics.
We have the same experience. Very, very rare reactions. 1 or 2, and quite mild over probably 8 to 9,000 examinations. So there has been maybe too much talk about this. Yes, you have to be cautious and ready for an allergic reaction any time you inject any type of substance in the heart of someone, in the human body of someone. But yes, the plus that contrast gives you is something that is really, really helpful.
And I think we should highlight that the safety profile of this kind of contrast is much better than the contrasts that are used in CMR and in
the iodinated
radiology, let's say. So
absolutely.
this is very important. So, other question. How could you explain the presence of left bundle block without coronary artery disease and fibrosis?
Well, I think it's very I think there is intrinsic myocardial dysfunction in this patient's case. The ejection fraction was reduced and the left ventricle was dilated. Now, obviously, we're seeing disease at various different stages. We can see it early, we can see it in the middle, we can see it more end stage. And I guess according to textbooks that we were trained under a few years ago, the description was more about the more severe end of the spectrum, What we're seeing is early stages now. And I think this patient, we're seeing early stages before you can actually visualize the mid-wall fibrosis, but clearly there is a problem. There is left bundle branch block, and the ejection fraction is not normal. So there is intrinsic myocardial disease, but I think we're seeing it at an early stage.
Yeah, and I think what we should highlight in this case that the fact that the patient had a normal perfusion study, put her not at the highest risk of developing a serious event.
Yes, absolutely. So the risk of an acute coronary event is obviously very low. And in any case, the CT coronary angiogram was normal. So in her case, it was really the myocardial dysfunction, intrinsic. That's the focus.
Another question. Is there any possibility that the stress echo is normal if the patient has multivessel disease?
Absolutely. Absolutely. What we have seen many times, this is thought to be more specific to vasodilators, but you can see with albumin and with exercise. If you have balanced ischemia, it will be very, very difficult to see wall motion abnormalities. What we really assess is something compared to another place, another segment of the left ventricle. So whether you have a reduced perfusion at stress, which is diffused in all the three coronary territories, it will be very, very difficult for you to see wall motion defects. This is different for perfusion. You usually can see several perfusion defects in three vessels.
I think you showed the case.
Yes.
With multiple
basically, the point is that the key point is that perfusion is very, very much sensitive towards CAD, to a reduction of flow. And this is also a problem for perfusion, which is probably oversensitive towards obstructive CAD, if we use that as an endpoint. So perfusion is assessment of perfusion is much more than coronary artery disease. You can find in some types of myocardial dysfunction and other cases. You can see in Takotsubo disease, microcirculation, you can see. So this is not specific for CAD, so we should not call a false positive if we find a reduction in myocardial blood flow at stress without coronary artery disease. It's simply another disease. Right?
Absolutely.
And of course, it depends what we mean by multivessel disease.
Yeah.
You may have, non-significant lesions in terms of functional testing. You may have a 50, 60%, 70% narrowing in 3 different vessels, but it doesn't necessarily mean they have to be ischemic.
Yeah,
and equally, you may have occluded vessels with very good coronary collateralization.
Absolutely.
And you do not have to have much ischemia. So we're looking at 2 techniques which look at different aspects of coronary artery disease.
Yes, but also a territory may become very ischemic if the lesion is very tight, and then the other lesion can be unmasked because you don't you don't go farther in the
Absolutely.
test.
Yes, absolutely right.
Isn't it?
Absolutely right. Absolutely right.
So time flies, and we are now approaching the end of this webinar, and I would like to close this session by summarizing the key message for your daily practice. Contrast stress echo improves wall motion assessment in our daily clinical practice. It gives confidence to the interpreters in wall motion assessment. It is a cost-effective technique compared to exercise, ECG, and other modalities. Perfusion is highly feasible during stress echo and provides additional information, not only in diagnosing, but also gives prognostic information. We will now close the webinar. Thank you to Dr. Kattar and to Dr. Gaibazzi for their very informative presentation, and I would like to highlight that this program is supported by an unrestricted grant by Bracco Milan, Italy, in the form of an educational grant. You will be able to watch this webinar again on demand on the EACVI website within a few days, and we will be able to answer all the questions that we couldn't answer within the constraint of time. Maybe we have 1 more minute to answer one more question. What is your opinion on the future role of stress echo after the ischemia trial?
Do you want to reply?
I think we should reply to this.
Yeah. Well, I think there will always be a role for functional testing. As I showed in the first case, we had the patient, the second case with the CT coronary angiogram, which was abnormal, but we still need to know about their function. How much can they exercise, and actually how much ischemia is there? I want to know if the patient with chest pain actually has ischemia. And CT coronary angiography does not really tell you that.
Absolutely.
The only tests that look at and ultimately it's ischemia that you're treating. And so I think functional testing will remain an important component.
Yes, and moreover, I think that this is just a point of prognostic stratification. The ischemia trial doesn't tell you that you don't need to find ischemia. But
yes, we only have 1 second. So.
Yeah. Okay, so
finished.